Now I invite Dr. Nitin Balakrishnan to give his talk on management of mature white cataracts.
Thank you, Sujata, for having me in your wonderful course over here. So, whenever we talk about a mature cataract, the most important thing is to differentiate between the types of the mature cataract. So, when we see a white cataract, basically you can either have a pearly white cataract without any liquefied cortex, or you can have a uniformly white cataract with liquefied cortex. Now, considering this case of a pearly white cataract, so if you see this pearly white cataract, there is no liquefied cortex. The chances of an Argentinian flax sign is very less. So we start off by making a side port, only a single side port. Note, I have not made the main incision. I'm putting in a trypan blue to stain the anterior capsule, and I'm injecting viscoelastic. The trypan blue is being egressed out with the viscoelastic injection. Now it's important here to see that the intraocular pressure is a little on the higher side, because a lower intraocular pressure would risk a sudden decompression of the fluid in case the fluid exists. Now we're making a small nick in the anterior capsule just to check whether there is liquefied cortex, because if there is liquefied cortex, then we need to change the plan. So here we see there is no liquefied cortex, so I can go ahead and make my main port incision, because now it doesn't matter if there is a little bit leak from the main port incision. Having done that, we go ahead and use a capsular access forceps to make a normal capsular access, which is quite similar to any other cataract. Here the risk of an Argentinian flax sign is very, very minimal, primarily because there is no liquefied cortex in these cases. These cataracts are usually the hard Morgagnian types. Important while doing hydrodissection to do a controlled hydrodissection and to do a multi-quadrant hydrodissection like Sujata had mentioned in her talk, and check whether the nucleus is freely mobile. We now go in and do a chopping technique, which is quite similar. The most important thing is to chop through and through in these cases. Now very often, in spite of having, when we assume that the nucleus has been chopped through and through, we find that the nucleus is not, the fragments are not coming out. Now this is because there is the central core which acts like a paperweight sitting upon the fragments. So once the central core is removed, so you will need to identify the fragment in which the central core is there, and that fragment, once it's removed, all the other fragments would come. Important to note here that my phaco probe is bang in the center. I'm not running after the fragments. Let the fluidics do its work. You, with all your lovely new machines, the fluidics will do the work. The fragments tend to come towards your phaco tip, and towards the end, it's important that your parameters are either you go into a low parameter, or you use your foot switch so that you don't have a sudden surge. The posterior capsule now tends to come, because there is no support in these cases of the epinucleus. The posterior capsule can keep bowing upwards. Again, if you're using a coaxial ion aspiration irrigation system, sometimes you get a blockage of the aspiration port, and you can use a second instrument to clear that blockage. And having done that, the rest of the job is pretty simple. You go ahead and implant your lens. After having implanted the lens, it's important to get the viscoelastic out, because in these cases you used a lot of viscoelastic primarily to prevent endothelial cell loss because of the hard fragments. I'll go to my next video. So this is a case of a white cataract with a liquefied cortex. Now it's important to understand here that in this particular type of cataract, there's a dual pressure compartment. So what happens is there is fluid liquefied cortex in front of the nucleus, and there is liquefied cortex behind the nucleus. And being a large cataract, there is an equatorial block. So what happens is, in these cases, when the fluid starts leaking out, the anterior fluid compartment collapses, because of which the fluid from the nucleus is pushed forward, and this causes an equatorial block, and this is the main cause of an Argentinian flag sign. So here you can see you can have an Argentinian flag sign at various stages. You can have it during the initial puncture. You can have it if you're trying to aspirate the anterior cortical fluid. You can have it even at the time of a hydrodissection. So there are various stages, and this is something which is a bugbear and which would really require a lot of patience to prevent this from occurring. So here again you're seeing that all the stages at which you're getting all the Argentinian flag sign. So what do we do in these cases is you create a positive pressure in the AC before the capsular puncture. It's very important that the intraocular pressure is high. Do not press on the posterior wound loop or the posterior lip of the wound. So the anterior chamber is pressurized so that the entire nucleus is pushed downwards. Do not aspirate the fluid cortex. It is important that you can clear this liquefied cortex with the viscoelastic, because aspiration of the liquefied cortex would lead to a sudden equatorial block. The initial rhexis can be made to 3 to 3.5 millimeters. This technique I've been following for the last maybe 10 to 15 years, and it's been a very safe technique in cases of these cases. Once having done this, do not do a direct hydrodissection without voiding the posterior fluid. So you need to rock the nucleus from side to side. I do that with a bimanual aspiration irrigation, where I'm aspirating the cortex, the liquefied cortex, as well as rocking the nucleus from side to side to break the equatorial block. And at the same time, the nucleus can be checked for rotation, so you don't need to do a thorough hydrodissection. And now the rhexis can be enlarged to a 5 to 5.5 millimeters. And having done that, you can proceed with the phacoemulsification, which is quite simple. So this technique is a very good technique where you have an initial small capsular rhexis followed by removal of the liquefied cortex by an aspiration irrigation, bimanual aspiration irrigation, and breaking the equatorial block so that there is no chances of getting an Argentinian flag sign. The other methods of rhexis, like Mohan mentioned, is the flax. I'll skip this particular video. You can also use a Zepto technique for doing a rhexis, which is again a simple technique, much cheaper than a flax technique, because the entire console and the disposables are cheaper than the flax. And it creates a very elegant method of doing capsular rhexis in these white cataracts. So the ring with the ninitrol ring is inserted into the anterior chamber. Vacuum is used to fixate it and centralized on the visual axis. And then a radio frequency of zap is used to create a perfect free-floating capsular rhexis. Today we also have something called as a capsule laser, which is another expensive tool. It is one of the tools which is available to create. Here you don't have to insert anything into the anterior chamber. It uses a high viscosity trypan blue which absorbs the laser beam and creates a perfect central capsular rhexis. The entire console of this, it's attached to the microscope. So these are the various techniques available which would prevent Argentinian flag sign, especially in these cases. I'd like now to go to a different type of chopping technique called as the flower petal chop, which is again very useful. So very often in these hard Morgagnian type of white cataracts, you see that it is not possible to go down and chop up to the core. So what we can do in these cases is just to separate the superficial nuclear tissue. So if you see, the chop is not going through and through. And again, if you see here, my chopper is not close to the phacoprobe. It's a little away from the phacoprobe. None of these chops have gone through and through. I'm just separating the individual areas in various quadrants. So the endonucleus is now being exposed. The hard endonucleus, the core is being exposed. And now, once the endonucleus is exposed, this endonucleus can now be phacoed. So you just have to lift it up with your vacuum. The core is now coming onto your phaco probe. Once this core is out, it's very simple to get the remaining fragments out, because this is usually pressing upon the remaining fragments. Again, an older machine, so a lot of turbulence and a lot of chatter. So the remaining fragments would then come out quite easily. So what is the take-home message? That not all white cataracts are the same. You need to differentiate the type of the white cataract to check whether there is liquefied cortex or no. Again, it's important that a good dispersive and cohesive viscoelastic is used. A soft shell technique in these cases will really work well. You need to have your optimized phaco power settings for the different types of cataracts in white cataracts. And you see to it that whenever you're approaching the final fragments, you tend to get your phaco parameters down, or go ahead and again inject viscoelastic so that there's no anterior bowing of the posterior capsule causing a rent during the last fragment aspiration. Thank you for your kind